All right, welcome everyone. This is the first CDOC quarterly cancer plan revision check-in meeting. My name is Shantae Davis Patterson, and I am the program director for California's Comprehensive Cancer Control Program, and we administer the State Cancer Coalition, the California Dialogue on Cancer, or CDOC. We're very happy for all of you to join us today for our very first quarterly cancer plan revision check-in meeting. On the line with us are all of you in our subcommittees, and we also have our team on the comp cancer side, Joyce Seha and Sheila Senyo. So our agenda today, we are going to go over a little bit of a background and review our timeline and some general guidance. We'll talk about the cancer plan development and communications. Then we'll go into all of your subcommittee updates. And then hopefully we'll have time at the end for a little open discussion and feedback. As I mentioned, here's our team here. In the middle, we have Sheila Senyo, who's our strategic alignment specialist, and she is the person who will help with any data acquisition needs you have. And then we have Joyce Para-Iko Seha, who is our coordination specialist, who many of you have been corresponding with in terms of getting meetings set up, et cetera. Thank you. And I also just wanted to show a list of all of the members on our Cancer Plan Advisory Committee. These folks have been working with us at the start of the year as we started to analyze data and collect all the feedback, analyze all the feedback to determine the outline and other foundational aspects of the plan. So this is our Cancer Plan Advisory Committee, and many of them I know are on the line and also a part of some of those subcommittees. So I also want to say thank you to all of our CPAC members, especially those who are on the line. We are happy to have Lindsay McDermott, who is with us now. And she is a contractor working with us through Sacramento State. She's assisting with cancer plan revision, coordination, writing, and editing. And many of you who may have been present at our June 4th meeting in Los Angeles may have met Lindsay because she was our facilitator. So Lindsay's also been helping behind the scenes as we got started with this whole process. So again, we're happy to have Lindsay, and she'll be a face that you'll see as we meet with these during these quarterly cancer plan check-in meetings. I love everyone's introducing themselves in the chat. Please do so in the chat, your name, organization, etc. Thank you. All right, so I just wanted to go over the cancer plan timeline quickly. You see, we're already at the point where we're having our meetings with our subcommittees. We have a couple of deadlines now that we want to share with you all. December 3rd is going to be the first deadline where we are asking for draft content and bullets for the next quarterly check-in. But what's the most important piece is the draft content. So we want to see what you all have come up so far in terms of the strategies and any action steps that you have developed thus far with your team. And then the final deadline for all of the strategies and action steps are going to be due on April 30th, 2025. So that's our date is April 30th, 2025. So again, our first draft, December 3rd, and then April 30th. And then you see the rest of the timeline here. We're planning to turn in the plan to the department July 1st of 25 to review. Thank you, Joyce. All right, just a reminder, general guidance. We have, as we started this process, and remember, this is, even though this is we've done many plans in California. This is the first time we're doing a 10-year plan, and the first time we're kind of moving away from just the cancer specific topics. And so we've had to kind of shift some of the priorities and or some of the guidance around the numbers of the priorities and strategies, et cetera. So this is just a revised table. I'll go into it a little bit further in the next slide, but just a reminder that we have sent this updated table through communications that Joyce has sent in the general guidance document. All right. And so one of the things that we've had to do with three of our committees, with health equity, with early detection and screening, and childhood cancer, is to split up the subcommittees because we had way too many folks who volunteered to help work on content. And so, we were aiming to have just around 12 people working in one committee. So with health equity, I believe we received over 30 folks who are helping us with health equity. So we have split the group up by priorities. So you see we have group 1, group 2, and group 3. And this is just a reminder that the number of priorities, the number of strategies and action steps, you have to look at how many priorities your group has. So for group 1 and health equity, they're working with 3 different priorities. They will have 6 strategies per priority and up to 10 action steps per strategy. And then for group 2, they will have up to 6 strategies per priority. And we just wanted to emphasize this because previously, before we broke the groups up, it was, health equity committee has X number of strategies and priorities, but now it's all broken up into different groups. It really is all based off of the number of priorities that your group is working on. So in general, it's just important to remember that you have up to 6 strategies to develop per priority and up to 10 action steps per strategy. And remember that it's not a requirement that you have 6 strategies and 10 action steps. That is just the max number. And we have put, limits on this because we are aiming to shorten the plan. We can't make the plan 500 pages. And we really just want to focus in on those most important things that are going to happen, for the next 10 years. And then also keeping in mind that we will have be able to assess the action steps. So the action steps will be able to change if we need to based off of the current environment and things like that. And then also just a reminder for the health equity content. We want to remind everyone to ensure that all your strategies and action steps have a health equity focus. And we have provided health equity liaisons that are able to assist for each subcommittee. And so you should have received a notice of your health equity liaison. Here they are here. Thank you all of you who have volunteered to be your health equity liaisons. Most all of these individuals are serving on the health equity subcommittee, but also on the group in which that they are assigned for a liaison duty. So we're very grateful for everyone who has volunteered for that piece. And then just communication, we will start putting a cancer plan update in the CDOC newsletter every month, so you can look for that. Other communication will be sent based on the projects and timelines, and those will come directly from Joyce. And then just reiterating who your contacts are for this process here with myself, Joyce, and Sheila. And all of this information is in the general cancer plan guidance document. So, and then a reminder for data and other requests. They may take up to 2 weeks. So please give us grace with that. And Sheila Sinyo is your contact for that. And the cancer plan roster, we have finally confirmed all members for this cancer plan revision process, and we're very excited about that. So you'll receive a final copy of this roster, and you'll, excuse me, you'll see that we have bolded your subcommittee leads. Some subcommittees have co-leads. And then we've also bolded and identified your health equity liaison for your subcommittee as well. All right, so let's get into the subcommittee updates. Now, the purpose of this portion is to help identify areas of alignment, duplication, and potential collaboration. So please, pay attention to what's going on and see, where you may find those opportunities there. And, we'd like to allot enough time for each group. So please only take up to 2 minutes to give your update, because we're going to be hearing from 14 groups. So just do the math on that. And again, please try to keep within your 2 minutes. All right, so I'm gonna just go ahead and let Joyce lead this part. And honestly, you'll see your name pop up here, but go ahead, Joyce.
For health equity, our groups this group has 3. And so I'm going to start off with group 1, which is the cancer prevention and screening outreach and partnerships. So Ernesto, if you're on the line, feel free to go ahead and provide your updates.
Thanks, Joyce. Yeah, so not a lot to report for us. At our first meeting, the majority of the people in the group couldn't attend. So it was just doing brief introductions and then coming up with a scheduled meeting time. So once the roster was created, we agreed on a meeting time and we'll start meeting next week. So that's just going to be really a kickoff meeting to, get to know everyone on the team and see what first steps we take.
Sounds good. Thank you so much. I will kick it to Shannon for the SOGI Plus data work group.
I don't know if Shannon is available. I think she may be out, but I'm covering in Shannon's absence.
Okay.
If that's okay, can I share the update?
Yes, go ahead, Jose.
Okay, great. So our team met and we brainstormed on several thoughts in terms of like how we would like to approach health equity. And so they're listed here. So having community cancer centers increase SOGI Plus data collection, and this is inclusive of trainings for outreach to the smaller clinics throughout the state, because we know education and training is going to help make a bigger impact for the collection of SOGI Plus data, increasing compliance of SOGI Plus data responses in electronic health records where the data collection is already an option. So again, offering training and resources to expand beyond the clinical office to include front desk staff, call center, basically any touch points for a patient. Because we know that our providers and clinicians, including nurses, they have the training, but does everyone else within that clinic or that health system have the training? So we want to make sure that we're expanding the training to everyone that has the ability to collect SOGI Plus data. Addressing language barriers is also really important, because we know that clear communication and cultural tailoring to that communication is really important. One size does not fit all. English is not going to cover everyone. And then having a patient-centered approach means providing patient education to explain why we're asking for this information, because we've heard from some of our patients that sometimes they do challenge why we're asking for SOGI Plus data. And so, being transparent and clear about those reasons are going to be one of the things that we're going to take on. And then policy support at the state level. So one of the things we talk about are what incentives make sense for health systems and clinics to comply with collecting SOGI Plus data, and what would those incentives look like? And so these are the kind of components that we'll be working on, with Shannon leading us.
Sounds good. Thank you so much, Jose, for providing these updates. I will pass it over to Stacy Anderson.
Okay, I think I'm on mute. You guys hear me now?
Yes.
Okay, great. Good morning, everyone. Okay, so what we did for our update is together as a team with just getting to know each other. We actually updated ourselves and went through the CDOC guidance document to understand what is required of us and to make sure we were understanding and in compliance of the ask we are tasked with. So we went over the information as a team, which was really enjoyable. So we could ask questions and get our questions asked. We went over who our designated speaker for our team, and then we went over also our meeting, our set meeting dates, and then we went to our priorities. And one of our priorities is to advocate for policies that address social determinants of health, increased number of Californians with access to equitable and quality health care, and what that would mean. But we also had increased number of Californians with access to quality health, promoting resources and equitable health care. But we wanted to expound on priority number 5 and a change of wording to expand access to quality health, promoting resources and equitable healthcare for all Californians with a focus on fostering healthy environments. So we kind of changed our number 5 from increased number of Californians with access to equitable and quality healthcare to expand it to that verbiage to expand access to quality health, promoting resources, because a lot of times we feel that people don't get the needed resources to acquire that equitable health care for all Californians. And then one of our team members brought about a very important part, which was the fostering of healthy environments, because it really matters what type of environment that someone is in order to even achieve any of those goals. So that was something that we wanted to present and see if that we could expand our priority 5.
That's
That
great.
was our update.
Thank you, Stacy. I will move over to cancer surveillance data. Terrence Kelly is the lead for this group.
You're on mute, Terrence.
Great. Can you hear me now?
Yes.
Yes.
Okay. All right. Thank you. So for our key updates on the expansion of the CCR data dictionary, we are suggesting to add detailed demographic information. And for those that are not too familiar, the California Cancer Registry is the statewide surveillance registry for the state of California, Cancer Surveillance Registry. And so the demographic variables that we are looking to add are specifically race and ethnicity subgroups and SOGI. The race and ethnicity subgroups that we are looking at for inclusion are American Indian, Alaskan Native, Middle Eastern, African, and Latinx communities. We also would like to collaborate more with NACER and some of the pathology organizations to understand more about what other states are doing in terms of data reporting and their cancer registries, looking at improving really the granularity in cancer types and subtypes. So there were some concerns raised about the aggregation of certain cancer types and aggregating different types into a single category can skew certain data elements. And so looking further into how different cancer types and subtypes are aggregated. And we've also identified additional areas for data linkages and potentially an area for maybe real-time reporting. And so linking CCR data sets with other external data sources would essentially create a more comprehensive and robust cancer surveillance system. And there are some, challenges that we've identified with real-time data reporting, but also would like to sort of research that a bit more. And we've been looking at the SOGI data collection challenges, and also one of our committee members is also part of the Health Equity Work Group SOGI Data Project. So we'll be working closely with them on sort of identifying some of the gaps and challenges in collecting SOGI data. Some of the other data elements that we thought about incorporating into the cancer registry were preferred language and financial toxicity data. It was an area where we'd like to research more and recognize the need to add preferred language and financial toxicity data as it can significantly affect the patient's understanding of their diagnosis and treatment options. And also had a large discussion since our last couple of meetings on how we can streamline access to the CCR data set. And we understand that there's complexity with California's IRB process, and that remains a significant barrier for researchers seeking access to CCR data. So that is a key goal and item on our subcommittee as well. And that includes my updates.
Thank you, Terrence. I'll go ahead and move over to childhood cancer. Misha Mehta is the lead of this group. I'm not sure if anyone from group one would like to, she's not available to attend. If anyone from group one is able to speak on her behalf. And if not, I can provide, I can read the updates that's here on the slides.
Joyce, these
Yes.
are the updates. I want to underscore the things we've identified as priority strategies for this priority. The advocacy and awareness, financial toxicity, and psychosocial support we thought were extremely important. And the advocacy piece and the financial toxicity absolutely, mesh with other subcommittees' priorities and strategies. So I just want to keep that in mind. But Misha did a great job with our meeting.
Great, thank you, Laura.
Mm-hmm.
Okay, let's move over to group two, childhood cancer. Christine, are you on the line?
I am. I'll be brief. We don't have all that much to report. We're looking forward to getting going at our next meeting. We're meeting the third Monday of the month. We were looking to the Wisconsin state report for some inspiration for goals, and we hope to refine them further at our next meeting. Anyone else who's on, if you have anything to add, please do.
This is Sarva. Just to add to Christina, I think we also get some data behind, survivorship and other things, right?
I see Christine shaking her head. Thank you, Sarva and Christine, for providing these updates. Before I move on to the next group, just thank you so much for all the important updates thus far. Again, as a reminder, if you're a designated speaker, please keep your updates to 2 minutes so we can allow enough time for Q&A after subcommittee updates. With that, I will pass it over to Katie Hess, who is the lead for alcohol prevention.
Hi, everyone. I don't have a lot of updates. We are just getting started as a subcommittee. We have our first subcommittee meeting later in the month. We'll be meeting also the third Friday of every month. One of the initial things that we've undertaken, though, is drafting a proposal very briefly for a new priority for alcohol prevention. And the current priority is decreasing alcohol use among high school students. And our new suggested priority is to increase education and awareness of the harms of moderate alcohol among young adults specifically. And we have pulled together some evidence for why this might be a good priority population for cancer prevention.
Thank you, Katie. Next, I will pass over to the Cancer and the Environment, and Laura Nathan will provide updates for this group.
Thanks, Joyce. So we identified our lead, Catherine Thompson, and we have our monthly meeting set. Probably the most important thing that we did at the meeting was talk about reworking our current priority to better incorporate social determinants of health, social environment, and disparities linked to communities. And we're going to use existing material, including the 2016 to 2020 environment chapter that was written for the California Cancer Plan that was never approved, and other states' plans. And so that's where we're headed. We really want to focus in on what we want to say. And we also discussed possible data sources that could be helpful, such as the Prop 65 list of carcinogens and the material available through Biomonitoring California. And I do have a question for, all of you, Shantae, Joyce, Sheila. We had talked at our stakeholders meeting about the issue of whether we were going to use social determinants of health or social drivers of health. And I just was wondering if we came upon a term that we're all going to be using.
No, we haven't dived into that yet, Laura, but we will. So thank you for bringing that up. But we'll circle back to that.
Thank you.
Thanks, Laura. I will pass it to William for updates on nutrition and physical activity.
So we have two co-leads, myself and Sandy Borowski, and we plan on meeting on Tuesdays. Which Tuesday remains to be determined. I did want to make a pitch for focusing more on encouraging the increased consumption of fiber-rich, minimally processed, polyphenol-rich foods as a way to get people to lose weight, instead of the old approach of asking people to basically engage in limited starvation, namely by limiting calories despite feeling some hunger, which has been the old approach and has not worked sustainably. So that's my report.
Thank you, Bill. For tobacco prevention, we have Stephanie Vong. Go ahead, Stephanie.
Hi, this is Victor. I believe Stephanie had said she wasn't available today, but I can, if Sophia's not on, I can provide the update really quick.
Sure. Thanks, Victor.
No problem. So our subcommittee, we have two leads, Stephanie and Sophia, and we discussed identifying partners who we can invite to the subcommittee, and then we also discussed how to cannabis use might be something to think about for our committee, and we established our recurring subcommittee meetings and hopefully be better prepared for our next meeting this month. Thank you.
Thank you so much, Victor. For HPV vaccination, I'll just go ahead and provide the updates. They convened their initial meeting, and there's one individual that was nominated for subcommittee lead, so that's just waiting to be confirmed, as well as monthly meetings being established. And then I'll pass it to early detection and screening, first with Haley Tepper.
Okay, so our first meeting is going to be September 19th, so we actually don't have a lot done yet. But to start, we've basically gone into the Iowa and Wisconsin cancer plans and realized that our priorities, which are 1 and 3, basically map almost perfectly to their priorities. So we've pulled out what they use just so that we're not reinventing the wheel, sort of keep that in mind. And then before September 19th, everyone is just going to brainstorm or like word vomit their ideas onto a Google Doc for our priorities 1 and 3, and then we can start sorting. One thing I'm anticipating as an issue or just something to address though is like we have, for example, like to implement healthcare system level strategies to increase recommended cancer screening and diagnostic services. That's our priority 3, but like when you look at priority 5, that's in health equity, it's increased the number of Californians with access to equitable and quality healthcare. So I'm just anticipating some like issues distinguishing between like, obviously that's the whole continuum of care. And this one's like more specific to the early detection and screening. But I already like as the liaison between the two, I'm like anticipating having a hard time sort of sorting out the overlap. And then also since like sometimes the priorities almost like specify the type of PSE strategy you're supposed to be using, like whether it's, if it says policy, it's just interesting that priority is already almost telling you like what your strategies are going to be. They're going to be policy strategies. So I'm anticipating there's going to be some like, we're going to have to sort between some of the health equity and like early detection stuff, because I think most of us are going to be thinking of PSE strategies that will advocate for the health equity component. So yeah, that's something I've just been thinking about, but we don't actually have a lot done yet so far. Okay, thanks.
That's a great point. Thank you so much, Haley. I'll pass it to Elise.
Yeah, hi. We've also just met once, and I think we just generally had a discussion about our priority, which is increasing utilization of cancer genetic risk assessment, family history, and counseling. So we just kind of discussed maybe what we understood about the current state of how those are happening, and then also discussed again, our current knowledge of certain barriers. Didn't put them on here, but things like limited genetics workforce, navigating criteria for genetic testing or insurance coverage, possibly, limited knowledge or awareness about how to talk about this from, non-genetics providers, and things like cultural considerations, especially when discussing family history.
Thank you, Elise. I'll move it to treatment and survivorship. Daniel, if you are on the line, take it away.
I'm on. Hi, good afternoon, everyone. Daniel Rivas, he, him, él. So we met, we introduced ourselves. We found out that there was a different range or wide range of experience. So that was great. We established our meeting cadence. What was really important for us, and we wanted to make sure we were looking at other state plans as well as the current California cancer plan, was to clarify and define, right? Some of these terms like non-clinical support services weren't very clear. What do we mean by that? So we wanted to look through some of our existing strategies and make sure that they made sense and that they were still clear. So moving forward, I think we also wanted to make sure that we were adding individuals with metastatic disease, as well as defining the survivorship term, what that looks like, when survivorship starts and when does it end. So I think that was also an important call out that the group wanted to make sure we included in our work. But moving forward, we were going to start a Google document for us to individually contribute strategies, and then we would talk through them as a group to see where there may be some overlap with other work groups. We wanted to make sure that we were including data, so they were data-informed strategies. and making sure we were also keeping an eye through our health equity liaison, but also through our experience on the diversity of the strategies, making sure that
Daniel, are you still there?
Sounds like we lost him.
All right. Let me go ahead and move forward. And with that, I'll pass it back to Shante.
All right, awesome. Everyone did a great job staying on time. So thank you very much for that. All right. I definitely heard some areas of alignment, duplication, and collaboration. Does anyone want to share anything that I know Haley has shared a couple of things, Laura? Any other thoughts or comments? This is the time.
Do I need to raise my hand? Well, how do you?
Well, go ahead, Stacy.
Oh, sorry. Okay.
No, you're fine.
So I just wanted to really think about, I wrote a note for me about health equity, right? Because for us, our group to dive in, what is equity? And what does that mean in the work that we're doing here? Equity could mean so many different things, right? And I think as we reestablished what our number 5 was, I think that's what we kind of was meshing out. Like, what is that health equity? And what does that mean across the diverse, different equity lenses that we will be looking at? And what does that mean? And I think as someone was talking about cross sector of work, I think once we pull out what that equity means in those different sectors of work, then we may find out that there's not a cross or an establishment that we need to make on what is health equity and how do we drive that. That was my thought.
Okay. Any thoughts to Stacy's comment? Oh, Christy, did you have another comment? Okay.
Yeah, just a separate.
Okay. But circling back to health equity, any thoughts from anyone on the health equity committee on Stacy's comment?
At least to me, equity is like if you were to split groups by some divider, whether it's like sex or, like race, ethnicity, whatever, way you're choosing to split things, like you should see the same outcomes or in both groups. Like you shouldn't be able to split a group and see significantly different outcomes for, I mean, obviously if there's like an age difference, then, there is some like outcomes that come with that. But if there's not like a clinical reason for there to be different outcomes, then you should see the same outcomes no matter how you divide things. That's I don't know, maybe a simplistic way that I think of it.
And that's the reason why I brought that up, because there will be different outcomes. And they have different drivers based on some of the things that you listed that will cause different outcomes. And I'm a patient, so I know that there's different outcomes. So thank you. Just some education there.
Christy.
Yeah, just to expand on some of Daniel's points for the treatment and survivorship, we identified a couple of questions to bring back to the health equity group as well as the pediatric group. So potentially seeing some overlap with, the pediatric group or childhood cancer in terms of lack of pediatric trials. So I know that we were interested in checking in with that group to see if you were addressing that in any of your goals. And then for health equity, Daniel mentioned that we were adding age as a category of diversity, but I think the broader question is for our health equity group and, CDOC as a whole, do we have a defined list of aspects of diversity that we're all working from? In terms of age, race, ethnicity, socioeconomic status, things like that.
Okay, to go to your first question in addressing clinical trials, anyone from childhood cancer? I did see Misha hop on. Hi, Misha. Are you guys addressing clinical trials at all? I'm not sure which groups.
I think that's going to be part of group priority 2 in terms of research and stuff. And in priority 1, we will be creating like a link to clinical trials because it's not going to be it's going to be a static document, right? Nobody's going to be updating it every now and then. So we could have a link in the resource section. That the priority 1 is mostly like resources for different aspects of childhood cancer. So we'll cover that but most detailed in clinical trials would be in priority 2.
Okay. So yeah, you see that connection there, Christy. And for these issues where, because I know there's also some alignment with cancer surveillance and the health equity group that's working on the SOGI piece. So for like those issues, we can definitely coordinate a separate meeting at some point. It doesn't have to be, like it doesn't have to be some recurring meeting or anything like that, but we can coordinate meetings to kind of address these issues to ensure, we're all on the same page. Like that's the purpose of this. So we can take note and identify where we need to follow up with those groups. So I've noted there with childhood cancer and clinical trials. And then to address your question related to the definitions and terms and things like that. Our team is working on that, but we haven't gotten, a whole list of everything right now. But that will be coming soon for everybody, just in terms of definitions and things like that. And also, even with health equity, social determinants of health, all of those things, because we all need to be on the same page and have a consistent voice. So I assure you that will happen. And as you know, in the cancer plan general guidance document, we have noted that there will be a narrative portion that we want from you all, but we just haven't identified those instructions yet, though that will be coming. But that's sort of how we're organizing all of this stuff. So just stay tuned for instructions on the narrative and all of the definitions and acronyms and things like that we're getting together.
Can I just add one quick piece on behalf of Shannon and the Health Equity Group?
Yes.
To address what Christy brought up in terms of defining a list of diversity that we're all working from based on like race, ethnicity, socioeconomic status. So my understanding is, the SOGI Plus surveys that were developed are in different phases. So there was one SOGI survey that went out to cancer centers to kind of assess, and there's a list of defined diversity elements or components to those surveys. And then there's the patient survey that we did, which has a different defined list of diversity variables that we are looking at. And then the next portion is the physician provider survey, which has its own elements of diversity diversity variables that we're looking at. And then the last one is the community survey, which I don't know that we've developed yet, but I think that's going to especially touch upon the socioeconomic piece. So I think, looking at all of those variables from all 4 of those surveys and combining them to have that defined list of diversity that Christy spoke about is going to be really helpful.
Absolutely. Yes. Thank you, Jose. Any other questions, thoughts, feedback?
Yeah, general thought.
Yes.
With regards to definitions, and I think it would be really helpful if we align our definitions that they're statewide, but they should also be comparatively identical or resembling other states so that there's a national norm so that we can have, uniformity when we look at it across the entire spectrum. So I think our definitions really need to be, excuse me, somewhat aligned with the national norm. Just wanted to put that out there.
Thank you, Gary. Bill, please.
Thank you. Yes, I wanted to bring up this implication for health equity in our group's change of focus from calorie restriction, which is accessible equally to anybody, to this focus on increasing consumption of minimally processed fiber-rich, polyphenol-rich foods, because there it's very well documented epidemiologically that there's a big difference in access to these kind of foods depending on your income. And so this focus, we think, is going to be associated with increased demand, that particularly in low-income neighborhoods that are viewed as food deserts, that they be given greater access to farmers markets, and that in our schools, especially in the low-income schools, that we do a much better job than we have done historically in providing minimally processed, fiber-rich, polyphenol-rich foods.
Thank you, Bill. Misha.
Yeah, I just wanted to follow up, like when would we get the data that we requested back, Shante, like just the timeline on it so we can plan in the next meeting?
Hi, Misha. Currently, the tentative timeline would be September 30th.
Okay.
Thank you.
All right, thank you.
Any other thoughts, feedback? Any other questions on any of the information we went over at the beginning before the updates?
I didn't catch some of that. Will that be sent to us? Will we have a copy of that? Are we able to get a copy?
Yes, we'll be sending out the confirmed roster that includes your health equity liaison and all of the leads on the subcommittees. The general guidance document, the roster also includes a breakdown of each of the health equity, early detection and screening, and childhood cancer groups within each subcommittee. So you'll have those names, those priorities, and those leads. In terms of the priorities and the numbers that you are allocated, that is updated in that general guidance document, which is also available on the Cancer Plan Revision website. And those were the major updates that we shared, and as well as the timeline. The timeline is, there's a place where that's posted on the website as well. And then of course this recording will be there as well.
Thank you.
Mm-hmm. All right, any other questions? There's the coalition website there, and as you all know, we have the separate cancer plan revision page that will stick updates on there. So this has been great. Thank you all for providing those updates. We know that a lot of you hadn't had a chance to get your committees together or just didn't get a chance to go through a lot of stuff we know we're just starting this process, but we have until April. And again, your draft I have to get used to not saying strategies and objectives, your draft strategies and action steps, or whatever you have at that point will be due in that first week of December. And we'll be sending out many communications via Joyce as well, and continuing to help you all organize your committees. We'll also be following up with instructions on narrative, and then how we're getting together some of these foundational aspects with, the definitions. So we're all on the same page with this. And then we've noted a couple of areas of alignment within some of these updates as well that we'll be following up with you directly. And on your screen, you see our upcoming holidays, just as a reminder, because we're state staff, so we're not working on those holidays. I'm sure most folks aren't anyway. And then our next quarterly meeting is December 10th, on a Tuesday. We'll have a new president then next time we meet. We want to thank you all for attending, and you all know you have our access to our emails, and if there's anything else you need, just let us know. Thank you everyone so much for taking your time to join us during your lunch hour, and also just volunteering your time for this effort. Thank you, everyone.